Thank you, Dr. Assalamu alaikum wa rahmatullah. Bismillah, wassalatu wassalamu ala rasulillah. My lecture will include the following topics. I will talk first about the decision to intubate, then the technique of intratracheal intubation, then we will talk about the complications. First, we will talk about the assessment of the proper position of the intratracheal tube, and then we will talk about the complications of laryngoscopy and intubation, and at last we will talk about the drugs that may be used in the setting of airway management. Edgar Stanley was pioneer in doing the first intratracheal intubation by using direct laryngoscopy in the year 1912. Even with the everyday development of new airway management tools and techniques, intratracheal intubation remains the gold standard of airway management as regards its unique ability to protect the airway against aspiration, and also its ability to provide efficient positive pressure ventilation without leakage and also without gastric inflation. Now we will talk about when to intubate. Even well-skilled clinicians can contribute to patient morbidity and mortality by delaying the decision to intubate and by converting a well-planned and controlled chance to secure the airway into a crash airway scenario. For example, in a patient with severe anaphylaxis and a burn victim with significant smoke inhalation, we should not delay the decision to intubate, because the projected clinical course is complete airway obstruction. So we should not delay intubation until the patient develops stridor. The decision to intubate could be obvious and clear. For example, in a comatose head trauma patient who will require immediate intubation. On the other hand, a patient with moderate respiratory stress who will improve with treatment and is unlikely to require invasive airway management. Between these two extremities lies a wide range of airway management scenarios in which the decision to intubate may be unclear. And when facing such clinical scenarios, we have to consider the patient's respiratory status, the pathological process, and the likelihood of deterioration. This is a simple approach that can help us to take the decision to intubate by answering 4 simple questions. The first is there failure of airway maintenance or protection? Is there failure of oxygenation? Is there failure of ventilation? And the last is there an anticipated need for intubation? In other words, what is the expected clinical course? Let's go through the first question, is there failure of airway maintenance or protection? Actually, patients who can talk clearly and answer questions appropriately demonstrates airway patency, adequate ventilation, and adequate cerebral perfusion with oxygenated blood. Because the perfusion or the level of alertness required to maintain the airway tone is the same that is required to protect the airway against aspiration. While the presence of gag reflex is not guaranteed that the protective airway reflexes are intact and aspiration will not occur. But the presence of a Glasgow scale of equal or less than 8 is a better indicator for the need of endotracheal intubation. On the other hand, the ability to swallow secretions is a better indicator, a more reliable sign of the presence of protective airway reflexes than the gag reflex. The following question is there failure of oxygenation? While anaerobic metabolism can maintain function in tissues such as skeletal muscles, more specialized tissues, such as especially the neuronal tissues, depend on oxygen, and irreversible damage will occur within a few minutes without adequate supply of oxygenated blood. Clinically, hypoxemia presents as restlessness, agitation, cyanosis, and as hypoxia worsens, there will be somnolence and confusion. Pulse oximetry can provide a reliable method for assessing the arterial oxygen tension, but in the setting of poor peripheral perfusion and hypothermia, it is unreliable. In the setting of emergency situations, clinicians should not rely on arterial blood gases. The following question is there failure of ventilation? Ventilation can be defined as carbon dioxide removal, which is the major end product of cellular metabolism. Ventilation could be impaired by central factors that affect the respiratory center, for example, trauma, diseases, and drugs, or by peripheral factors that may affect the lung, for example, bronchial asthma and chronic obstructive pulmonary diseases. Patients with chronic impaired ventilation can tolerate high carbon dioxide tensions due to gradual accumulation, but acute carbon dioxide retention will readily cause altered mental status and respiratory acidosis. Unless the cause of acute ventilation failure is rapidly reversible, for example due to drugs, we have to intubate the patient. And in selected cases, continuous positive airway pressure can be a good alternative. The last question is there an anticipated need for intubation? What is the expected clinical course? Inability to protect the airway, inadequate oxygenation and ventilation represent straightforward criteria for intubation. Yet, there is some emergency airway cases that not meet these criteria but still require intubation. A famous example is a patient with severe anaphylaxis and a apparent victim with significant smoke inhalation because the projected clinical course is complete airway obstruction, although the patient may initially show no signs of airway compromise. No guidelines or algorithms exist for this aspect of airway management, and there is no possibility to anticipate every possible scenario in which preemptive intubation will be needed. But we should consider clinical assessment including pulse oximetry, vital signs, the patient's mental and respiratory status, the patient's comorbidities, and the knowledge of the natural history with which the patient presents. All can guide the clinician regarding the need for preemptive intubation. Now we will move to the technique of intratracheal intubation. The aim of positioning and laryngoscopy is to create a line of sight from the mouth opening to the laryngeal inlet, so that the intratracheal tube could be inserted. If we look at that diagram in the upper figure, we will notice that we have three axes: the oral, pharyngeal, and laryngeal axes, and they are not on the same line. They are not aligned. That is why, if we look in some cases at the mouth opening, as my colleague Dr. explained, if we looked at the mouth opening, it is sometimes difficult to view the laryngeal inlet. That is why we do what we call the sniffing position. The sniffing position is an excellent position for both mask ventilation and intratracheal intubation. It can be achieved by elevating the head on a bed for about 10 centimeters. This causes flexion at the lower cervical spine. Flexion at the lower cervical spine. And causes alignment of both the pharyngeal and laryngeal axes. They were not aligned here. Flexion at the lower cervical spine by elevating the head on a bed for 10 centimeters causes alignment of both the pharyngeal and laryngeal axes. Now, extension at the atlanto-occipital joint in this area will bring the oral axis with the other two axes. Extension at the atlanto-occipital joint will bring the oral axis with the other two axes. Now the three axes are aligned, and this is the optimal position for both mask ventilation and endotracheal intubation. It is possible that the sniffing position is essential for all potentially difficult intubations, but it may be unnecessary for easier intubations. Now we will go through the actual technique of endotracheal intubation. Now I want to mention first that in trauma patients with suspected cervical spine injury, any further mobilization of the neck may cause significant damage to the spinal cord. That is why stiffing position is not only contraindicated, but also we have to limit any unintentional movement in the neck during laryngoscopy and intubation. But what we call the manual line stabilization, which can be performed by an assistant, this guy, and he can do this procedure by one of two techniques, either to stand facing the patient's feet and stabilizing the head and the neck of the patient, or to stand facing the patient's face and do the same. Now we'll move to the actual technique of endotracheal intubation. The laryngoscope is held in the left hand, and the blade is introduced to the right side of the mouth, so that the flange of the blade will keep the tongue to the left side. We have to avoid like this. We have to avoid damage to the lips, gums, and the teeth during introduction of the laryngoscope. When the epiglottis is visualized, if you are using the curved Macintosh blade like this, you have to move the blade step by step until the distal end of the blade is inserted into the vallecula, which is a depression between the back of the tongue and the superior surface of the epiglottis. And if you are using a straight Miller blade, the distal end of the blade will be pushed distally beyond the inferior surface of the epiglottis. That means that the epiglottis is included in the structures which will be lifted up by the laryngoscope. At that stage, you have to pull the laryngoscope up and forward. You have to pull it upward and forward, so that you will elevate the structures and to explore the glottic opening. Actually, this movement should be done by your shoulder joint, not by your wrist joint and not by the elbow joint. You have to look your wrist joint and the elbow joint and do this movement like this, not like this and not like this, otherwise you will cause significant damage to the patient's upper teeth. When the glottic opening is visualized like this, and this is a closer view, where this is the epiglottis, this is the open vocal cords, this is the arytenoid cartilage, and if you concentrate, you will see the tracheal rings. At that stage, the endotracheal tube inserted along the right side of the mouth to be passed between the open vocal cords under direct visualization. Then you have to ensure the correct position of the endotracheal tube. You have to make sure that the distal end lies in the mid-trachea by many methods which will be described later on, inshallah. Then you will have to fix the endotracheal tube. Now we will move to the assessment of the proper position of the endotracheal tube. Actually, one of the most serious complications is undetected esophageal intubation. That's why we have to confirm the correct position of the endotracheal tube. The first technique is direct visualization, then chest expansion, then auscultation of the lungs and the epigastrium, then pulse oximetry, and the last is capnography. The first technique of assessing a proper position of the endotracheal tube is direct visualization. It is one of the most reliable signs, is to visualize the endotracheal tube passing between the two open vocal cords. But sometimes in difficult intubations, it may be impossible to be achieved due to multiple factors. We have to remember always that after visualizing the endotracheal tube passing through the vocal cords, and you are sure now it is endotracheal, the tube may be unintentionally displaced For example, prior to or during securing the tracheal tube, during repositioning of the patient. Even flexion and extension of the head can cause change in the intracheal tube position. Chest expansion may be one of the less reliable methods for assessing intracheal tube position by observation of symmetric and bilateral chest wall expansion. And also, again, sometimes it may be difficult, for example, in female patients with heavy breasts, in obese patients, and in patients with increased chest wall rigidity. And also we have to remember that movement of the chest wall simulating lung ventilations may occur with esophageal intubation and gastric inflation. That is why this method is somewhat unreliable. Auscultation of the lungs and epigastrium when performed by experienced clinician could be a reliable method for assessing the intracheal tube position. And auscultation of the epigastrium, right and the left axilla, is more reliable than auscultation of the front of the chest. Pulse oximetry may be useful in many conditions, although it may be a late indicator of esophageal intubation. It will take some time to change. Capnography, the last and the most important, is the most reliable method for assessing a proper position of the intracheal tube. It is something important also, it is independent on experience, requires no experience. This can be achieved by observation of the characteristic capnography waveforms seen with the tracheal intubation, which are totally different from the irregular and rapidly diminishing waveforms seen with esophageal intubation. Now, what are the complications of endotracheal intubation? The first is trauma. The teeth may be injured during introduction, and if we did a fault technique during lifting up of the tissues with the laryngoscope, as I mentioned before, if a fragment or the whole teeth can be located, we have to do chest and abdominal x-rays for localization. The soft tissues could be injured by the laryngoscope, mainly the lips and the gums. In patients with cervical spine instability due to congenital, traumatic, neoplastic, inflammatory, or degenerative causes, any neck mobilization during laryngoscopy and intubation may cause significant damage to the spinal cord. Also, the distal end of the intracheal tube or the stylet may cause mechanical damage to the pharynx, the larynx, the esophagus, and even to the trachea. Hypoxemia and the hypercarbia are potential complications of laryngoscopy and intubations that are not successful in a reasonable time. Pulse oximeter and capnography are essential for detection of hypoxia and hypercarbia during this time. Aspiration. There is high risk of aspiration in a patient with full stomach and difficult airway, but I want to mention that aspiration could still occur in a properly fasting patient and in patient who shows any special difficulties. Aspiration is one of the fatal complications. Rapid sequence intubation with cricoid pressure and awake intubation have been described as methods for decreasing the risk of aspiration. Cardiovascular responses include hypertension and arrhythmias. Bradycardia can occur in children, and if bradycardia occurs in children during intubation, hypoxemia must be considered as the primary cause. Laryngospasm and bronchospasm could occur in predisposed individuals. Even topically anesthetized airways can still show reflex bronchoconstriction by the mechanical irritation of the intracheal tube. Patient with increased intracranial tension and who shows minimal reserve in intracranial compliance is actually at risk of brainstem herniation and sudden death during laryngoscopy and intubation. Esophageal intubation, as we mentioned before, is one of the most serious complications of the endotracheal intubation. It occurs most frequently in the setting of inexperience, but I want to mention also that it can occur to experienced practitioners. It can result in serious complications. The least is hypoxemia, but it can reach up to death. Endobronchial intubation causes hypoxemia, bronchospasm, atelectasis, and coughing. Observation of the chest expansion and auscultation of the chest can suggest the diagnosis. We have to remember also here what I mentioned before, that the endotracheal tube position may be displaced to change its position during repositioning of the patient and during flexion and extension of the neck. Flexion can cause distal migration of the tube up to endobronchial intubation, and extension can cause cranial migration of the tube up to the extension that it may be displaced from the trachea. Now we will move to the last issue of my lecture, the drugs that may be used during intubation. Actually, it may be used in the setting of airway management, not only during intratracheal intubation. The procedure of laryngoscopy and intubation is extremely stressful. This is because of the very rich sensory innervation of the areas manipulated during this procedure. This stress response includes hypertension, dysrhythmias, myocardial ischemia, and increased intracranial tension. In healthy individuals, stress response may be tolerated, but in patients with limited coronary and myocardial reserve, myocardial ischemia and failure may follow. That is why we have to use some medications to blunt this stress response. On the other hand, I want to stress that patients with cardiovascular and respiratory compromise and patients with concern over possible regurgitation and aspiration, we have to avoid this medication, or at least we have to titrate the dose. The first category is pre-treatment medications, which include fentanyl. This is a narcotic analgesic given by the intravenous route. It causes analgesia and sedation. It blunts the stress response, but high doses may cause hypotension and increased chest wall rigidity. Lidocaine is an amide local anesthetic given by intravenous route to blunt the stress response. It is useful in patients with bronchial asthma. Atropine and glycopyrrolate are anticholinergic medications given by the intravenous route to decrease the secretions and increase the heart rate. Procronium is non-depolarizing muscle relaxant. It is given in a very small dose in this setting to decrease muscle fasciculations and decrease potassium release from the cells, especially in patients with chronic renal failure, if succinylcholine is intended to be used. If you are intended to use succinylcholine for intubation, it is very useful to use a very small dose of non-depolarizing muscle relaxant like procronium before the use of succinylcholine, to decrease the muscle fasciculations and decrease potassium release from the cells. But higher doses of this non-depolarizing muscle relaxant may cause prolonged paralytic effect. The good news is that this is my last slide. The induction medications, the second category, includes etomidate, which is an intravenous anesthetic. It has a minimal effect on the cardiovascular and the respiratory center, on the intracranial tension. So it is very useful in patients with hemodynamic instability, in a head trauma patient with increased intracranial tension. Ketamine is another intravenous anesthetic. It has many advantages, and also it has many disadvantages. For example, it has a bronchodilator effect. It has analgesic effect. With ketamine, the airway protective reflexes are intact. The other disadvantages may include the sympathomimetic effect, increased blood pressure, it increases the heart rate, it also increases the intracranial tension. So it may be beneficial for patients with bronchial asthma, patients at risk of aspiration, in hemodynamically unstable patients because it has a sympathomimetic effect, but it is contraindicated in hypertensive ischemic heart patient and thyrotoxicosis, increased intracranial tension. Propofol is another intravenous anesthetic. It has a brain protective effect, but it causes a significant and dose-dependent cardiovascular and respiratory depression. The last category of these medications is the paralytic agents. Succinylcholine is a famous drug. It has advantages. It has more disadvantages. It is the drug of choice for emergency intubation because it had a rapid onset and it had a brief duration of action. So, as I mentioned, it is the drug of choice in emergency intubation. It has many side effects, for example, muscle fasciculations and myalgia, hyperkalemia, which may be fatal, very dangerous in a patient with chronic renal failure. It also causes bradyarrhythmia, especially with repeated doses. Rocuronium could be used by itself alone for intratracheal intubation as non-depolarizing muscle relaxant because may be equal to succinylcholine in its rapid onset. It has a minimal effect on the hemodynamics, causes less histamine release, but it may have prolonged metabolism and prolonged effects in patients with hepatobiliary diseases. Thank you.